or do you want us to wait?
Doctor, it's your wish. You can start if you want.
So they are not obligated to turn on their cameras, because I know in the fifth year everybody has to turn on their cameras.
No, doctor, they don't really turn on their
Okay,
cameras.
that's fine. Then we'll figure that out hopefully in the fifth year.
Okay, yeah.
Okay, good.
Okay.
Let's. I think I'd
Okay,
like
doctor,
to.
you can start. Yes.
Thank you. Thank you very much. Hello, everyone. I'm Professor Alhazza. I am your course director. I will be giving you, I'm hoping that each and every one of you has actually um, listened to my five lectures that I have given. I will be at the moment now, because of the COVID, only be giving you one live lecture, which will more or less cover, if you will, the five lectures I have given you. I've chosen certain topics that I think are important, but it does not mean that the other topics are not important. So I'm hoping that each and every one of you has gone through my five lectures and understood them. What you have to remember, and I think it's really very important, if you want to be successful as a physician, if you want to be a leader in your field, and I'm not just talking about a leader as a physician or in the medical, but also um, doing other extracurricular things, which I know I have done for a very long time. You have to remember you have to read and read and read to be good at what you do, to be successful at what you do. There are no shortcuts to medicine. If you do take shortcuts to medicine, it will help you for 1 year, maybe a couple of months, but it will not help you in the long run. When you come to me in the fifth year, and we have much more smaller groups, I will be talking to you a lot about your body language. I can't talk to you about your body language because all I'm seeing is names. And I will also be talking to you about leadership pearls, how to become a leader in your field. This is really very important. I'm also a professor at the University of Southern California, and I do give lots of lectures to the students there regarding their body language. Your body language is very important. How you look, you talk, eye to eye contact, and make sure your voice is loud and clear with no hesitation. All right. Now, when we talk about ophthalmology, truly we are talking about all these ophthalmic instruments, if you will. That's what the ophthalmic instruments are important. Um, we cannot, as ophthalmologists, be ophthalmologists without our instrumentation. It is very important. Now, you are not entitled to know all these instruments at all as a second year medical student, but I do want you to know the direct ophthalmoscope. You cannot finish your ophthalmology rotation regardless if you're going to go into ophthalmology or not, because it is very competitive, without knowing how to use your direct ophthalmoscopy. 12 years ago, when Dr. Khalid Ghatan requested that I come and be the director of the ophthalmology, I had not used the ophthalmoscope for years and years, because we as ophthalmologists use something called the indirect. I had to go back and teach myself how to use the direct ophthalmoscope, simply to be able to teach you as students direct ophthalmoscopy. It is really very important. The reason you need to know it is because it can save a life, which I'm going to be going into shortly. Another instrument I'd like you to know, and this is not, you'll never use it, but it could be a multiple choice question, is the difference between an ophthalmoscope, which an ophthalmologist uses, and a retinoscope, which a optometrist uses. You have to remember there is a difference between ophthalmology and a difference between optometry. Ophthalmology, we are physicians. We are medical doctors. We graduate with an MD degree because we go through everything and then we specialize in ophthalmology, whereas a optometrist is in the health system but is not a medical doctor, and he uses this retinoscope. His life is the retinoscope. The optometrist's main is to really see the refractive condition of the patient's eye, which means does the patient need glasses or not. This is the main. They do other things much more, but their main is really to use the retinoscope. Has nothing to do with really seeing the retina. It's the reflex of the retina, and it's used by the optometrist to see your refractive conditions, myopia, hyperopia, or astigmatism. We also use the slit lamp. It's a table mounted microscope. This is me in my very early ages when I was still, I think, when I was still a consultant. I have been the head of ophthalmology and the head and chairman of ophthalmology for the last 24 years. They call me the longest. And it's simply because it's really very important that the people that work with you do not work for you, but work with you. And it's really very important that when anyone that works with me, I make sure that they are not just doing a job, but they are going up the ladder and improving their career path. And it is always my pleasure when they come and they say, we have been promoted elsewhere, and I give them my full recommendation. So you're going to be seeing the slit lamp when you come to the fifth year. It's just a mounted, and it's really, really important because it shows us all the layers of the cornea and it goes into the eye. So I guess the question would be, why should you be interested in the eye? Why should you, as a medical student, care about the eye if you are not going to be an ophthalmologist? Really an important question, because whatever field you go into, whatever field, whether you're in the emergency room, pediatric, internal medicine, endocrinology, you name it, whatever field you are in, it is really very, very important to understand the background of ophthalmology because you're going to be referring a lot of patients. I think an important thing, you are taught right now what is an emergency. You have to preserve life. You have to preserve the limb. And this is worldwide, it's international. And you have to preserve the eyesight. So you have to understand ophthalmology, not to be an ophthalmologist, but to be able to direct your patients to the ophthalmologist because the eyesight is an emergency and you have to be able to preserve it. Diagnostically and functionally, it is the most important square inch of this body surface. Although it's small, but I will tell you, it is the most important organ in your body surface. So it's really very important to understand ophthalmology. Read whatever you can because that will make you a better ophthalmologist. I remember after I finished my fellowship here in Saudi Arabia, and I decided to go to Johns Hopkins Hospital, and I did my 3 years fellowship there. One of my year fellowship was in pathology. I knew that I would never go in pathology. I'm not interested in pathology. And I knew I would never be a pathologist, but I went and I did 1 year pathology because I wanted to understand the basis of diseases. And the only way, I told you, you can be successful in your field, the only way you can be a leader is you have to really have a ground and foundation. You really have to have a sound foundation. The only way you can do that is by reading and reading. And doing pathology for 1 year really helped me because after I came back, I sat for my FRCS, and I will tell you, had it not been for my pathology 1 year training, I would not have also gotten my British fellowship. So therefore, I have 3 fellowships, which is the Saudi, which is the American, and last but not least, the British from Edinburgh as the Fellow Royal College of Surgeons. All right. So I just need you to know this is the cornea. It's very much like your watch. This is why I buy this watch, simply to show my students. You don't see the light, the transparent part, which is the glass, but you do see the dark part, right? But you do know that there is glass, and you know between the glass and the dark part is a space. So consider the glass of the of your, if you will, of your watch is the cornea. Then between your cornea and your iris, which is the colored part, that's your iris, that's your colored part, is a chamber, or is a space that we call anterior chamber. You have to know it. What circulates in the anterior chamber? Aqueous humor. Where is it produced? It's produced by the ciliary body. What else does the ciliary body do? In addition to producing the aqueous humor, which keeps the globe functioning, it also suspends the zonules for your lens. Now we're coming to the lens, and it helps in accommodation. Now I know as second year, you will be getting a question on accommodation, so read on it, please. Then, of course, you have your lens, which is your clear part. This is where all the focus happens. And then you have your vitreous, which is the gel. Then you have your retina, and here is your macula. So if I was to draw a line of the visual pathway, it would go like this. It would go from your cornea into your anterior chamber, into your lens, and again into the macula. That's your visual axis, if you will. Now, there it is. That's your visual axis. Let's look at the eye. I told you you have to know the eye because it's part of the brain, and the brain is part of your body. So here we have the eyes, as we have here. You have the retina. Sorry, I missed it here. This is your optic nerve. So you have your optic nerve. You can see it nicely here. Then you have your optic chiasm. When you come to me in the fifth year, I'm going to be teaching you a lot about lesions in the optic chiasm. Then you have your thalamus, and then you have your occipital lobe. Please, you have to know what your visual pathway is. I don't have time to go through it. I'm only giving you a drop. Please read it. It is really very, very important. You have to know your visual pathway in order to get your MBBS. So let's talk a little about anatomy. If I was to take the lid and I was to take a cross section here of the lid, you can see it very nicely here. You have your skin, you have your muscles, you have your hair follicle, you have your glands, and really, really important, your tarsal plate. If I was to go here and look at remember I told you the cornea, between the cornea and your iris, which is the colored part, is a space. There has to be an open angle. Your aqueous humor, which circulates, is produced by your ciliary body. It goes through the zonules. It goes through the posterior chamber. This space here is called your anterior chamber. So it gets secreted, produced by the ciliary body, goes through your posterior chamber between your iris and lens. Then it goes through the posterior chamber into your anterior chamber, and then out through Schlemm's canal and trabecular meshwork. Let's look at this cornea here. If I was to take this cornea cross section, you have to, this is an important multiple choice question. It is 5 layers. Your first layer is your epithelium. You don't have to really know. Your last layer is your endothelium. I only concentrate on the epithelium and endothelium for you. Really important to know. Remember, I told you about the aqueous humor. This is what it does. The aqueous humor is here. Why is the cornea clear? It's a vascular. What does the endothelium do? We always like to call it the endothelium pump. It pumps away the aqueous humor so it does not go into the stroma. What is unique about your epithelium? Your epithelium regenerates. So anytime you have any pathology in your epithelium, the good thing about it, it continuously regenerates. Let's go now to the back of the eye. See if we would go here. This is the back of your eye here. So if we look back here now, we're taking a cross section of this. And if we take a cross section, this is what you see. You see your retina, and then you see your retina. Then there is a dip. That dip is called your fovea. You see it here. And this is called your macula. Please understand it. This is your optic disc, very nicely shown here. This is your macula, which is here. This is your fovea, which is totally avascular, like the cornea. And it's right there smack. And then this is all your vascular network. The dark are your veins. The light are your arteries. And we're going to be showing you some nice pathology. So this is your optic disc. This is your macula, and this is a cross section showing the 11 layers of the retina. This is your choroid. So you have your retina. Let's go back. So here, what do you have? You have your retina, your next layer, your retina. Your next layer is your choroid. It's here. Your last layer is your sclera. That's the white part. If you look into the mirror, you will see the white part of your eye, which is up here. This is what you're seeing. So you have your retina, your choroid, and your sclera. Let's move on. So let's look at the optic nerve. This is cranial nerve 3, which is a very important part of your globe or your eye. If you take your optic nerve, this is actually your optic nerve here. This is it here, optic nerve, optic nerve. This is your optic nerve. What you are seeing when you use, remember I told you the direct ophthalmoscope, you're going to be learning how to use it. When you look at the, when you look with your ophthalmoscope, you cannot see the nerve. The nerve, you only see it through imaging, CT scan, MRI. But what you do see is the head of the optic nerve, which we call the optic disc. So that is the only visible part to you right here, the optic disc. If you look at the optic disc in the back, it has the nerve. So what you're seeing is the optic disc. This optic disc, I think you see this is a healthy optic disc. I can see the margins, nice and pink, orange, and I can follow all the vessels. If you look here, this is engorged, it's raised. I cannot follow the margins, unfortunately. Look at this. I cannot see the margins. I don't know where they are. There is the little hemorrhage here, and most important is all your vessels are engorged. You can see that. All these vessels are engorged, and then you cannot trace them. So this is what we refer to as optic nerve swelling, which is papilledema, or you can also call it optic disc edema because it's the disc you see. We also have another entity, which is called optic atrophy. Now here you can trace the margins really nicely, and you can see all the nice vessels here. So this is pale. It's almost like it's a chalky white. So we refer this as optic atrophy. Then of course we have cranial nerve 3, 4, 5, and 6. And these are really very important. When you're asked, what does the cranial nerve supply? You will say the cranial nerve supplies all the muscles of the eyes except 2. So the cranial nerve, when you get a multiple choice question, supplies all the muscles of the eye except 2. SO4, superior oblique is supplied by the fourth nerve, and LR6, lateral rectus 6. So your cranial nerve supplies all except SO4, superior oblique, and LR6. Remember these mnemonics, really important. Visual acuity testing, you can either test it by using the metrics 2020 feet, or by 6/6, which is meters. You will be learning this in the fifth, when you come into your fifth level. We always use the Snellen chart. Pupils are really important. You have to know the pupil, the shape, the reactivity to light, and reactivity to accommodation. And it's so easy to do it, by using a simple torch, okay? This baby here, unfortunately, is abnormal because this is the normal. You have a nice red reflex when you use your ophthalmoscope. Here, there is no red reflex, unfortunately. So this baby was diagnosed with a tumor of the eye. So the normal. So if someone is born in your family, just take the ophthalmoscope. You should have your own ophthalmoscope and just look, and you should be able to see in any normal baby that is born in your family a red reflex. Red eye, very common. Everybody complains of red eyes, especially in this part of the world because of dryness. If you look at this is your lids, your upper lid, your lower lid. This is your canthus, the canthum, both here. So here is your conjunctiva. Remember I told you there is a sclera, your white part, then the choroid, the retina, and then the vitreous. Here is your conjunctiva. Your conjunctiva has the vessels. So when your eye becomes red, this is what you're seeing. There are so many causes. I gave you a really nice lecture. Please go back and listen to it again, because the conjunctiva has so many structures by it. It's got the eyelids, so anything in the eyelids will cause conjunctivitis. Anytime you put itis, it means pathology. Your cornea, anything in your cornea causes conjunctivitis, your iris, and your ciliary body. So this is your differential diagnoses of your red eye. I'm not going to go through it. I just put it up for you as a review. The ones that I have in yellow, these are emergency, and you have to attend to these patients immediately or they can lose their sight. This just simply shows a beautiful diagram of your eye. Please look at your upper lid, lower lid, conjunctiva. Your limbus is the conjunction between your cornea, which is clear, and your sclera and conjunctiva. That there is called your limbus. All right. When we talk also about red eye, you're going to be hearing a lot what we refer to as pterygium or pinguicula. Simply, this is because when the laborers unfortunately do not wear glasses, so the ultraviolet light affects them and it causes a pinguicula. The pinguicula does not reach the cornea or the limbus. Very easy to treat by telling them to use lubrication and glasses. But unfortunately, if they continue not to wear glasses, it will develop into a pterygium, which means now that little pathology has now come into the cornea. This is really devastating because then we have to do surgery to remove it. I get asked this a lot, and you will as a medical doctor, because people look at you as medical, about a subconjunctival hemorrhage. I put it up. People are really, patients or your family or relatives really get freaked out when they see this hemorrhaging, but you can tell them not to worry, even this, because this is in the outer part of the eye, and it's usually due to valsalva. Patient is coughing or straining, having constipation, can be due to trauma. You ask the patient, do they have hypertension or do they have any bleeding disorders? You give this patient about 10 days and it will disappear. Usually, hopefully, we hope that it disappears in 5 days. So always reassure the patient and tell them, I get a lot of photos sent to me in WhatsApp. My friends call, relatives, colleagues, that I tell them, Do not worry. Corneal abrasion, we talked about it. Remember, we said what's unique about the epithelium? It regenerates, regenerates. So any pathology to the epithelium because of a corneal abrasion, usually you can technically scrape it, maybe with a pin or an object. A mother is breastfeeding her child and he pokes her eye. It's really very, very painful. You get a foreign body sensation and tearing. But the nice thing about the corneal abrasion, because the epithelium regenerates, 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 it will heal with treatment. This is just a fluorescein. This is what we have, what we call a fluorescein dye that we put on the eye. And then by using the slit lamp, we put the blue light and you see it, we call it cobalt blue. This is really very easy. Another important corneal pathology is what we refer to as herpes zoster. You get a lot of vesicles. This is when people have before the smallpox. So you get a lot of vesicles. The nice thing about it, you can differentiate it. It respects the midline. This is really very important. So it respects the midline, as you see here. And then you look at the cornea, and you have what we call this dendritic dendrites. Again, with good with the prompt diagnoses and good treatment, it will heal because the epithelium regenerates. Strabismus is also another very important topic. I put you the topics that you'll be asked about by your family, friends, and relatives and colleagues. So this is the normal eye, and unfortunately, this eye is going in. The reason I put this eye going in, you will ask this in multiple choice question. And esotropia, where is the light pointing to? You have to read about it. So you have 3 for strabismus, but I only put you esotropia. You have esotropia, exotropia, and hyper, up and down. So this is your normal red reflex, your normal corneal reflex. Should be in the center, should be right there. Unfortunately, the reflex is actually beyond. So please read on this on your own. You have to remember you have 6 extraocular muscles, and each of these muscles does a certain movement that I'd like you to read about. The most important thing is with strabismus, it does occur in 2% of patients under the age of 3. Very, very important. This is what you have to remember. Is your mother and father, they feed you until you are 18 years old, because that's your growth spurt, right? You grow and grow until you're 18. After 18, you don't usually grow. Unfortunately, for the visual function, it is until 6 years. So if someone has strabismus, it is really very important that they are treated during these 6 years. If you diagnose someone after 6 years with strabismus, we cannot do anything for them. Your best age is 2 to 4. So if you see anyone in your family, your relatives, your colleagues, your friends, and they have their siblings or their younger have strabismus, please tell them immediately go. They give them glasses, patching, or surgery. So this is your muscles. You have 6 muscles in each eye that control the eye movement. Please, this is really very important for you to know. And then the 3 cranial nerves control these muscles. Nerve 3, 4, and 6. We said 3 controls all these muscles. Number 4 is SO4. And then number 6 is LR6, lateral rectus. Please remember that. Accommodation, you will always get asked about accommodation. This is when your ciliary muscle, where your ciliary body contracts, and it causes the natural lens to change its shape, and it allows images to be focused. So please read this on your own, really important. What are the common ocular conditions that can cause strabismus? So when someone has strabismus, do not think it's just strabismus. There could be causes. God forbid, what worries me always is a retinoblastoma. You can see it here. This is a retinoblastoma. There should be a red reflex here, but the way the photo was taken, retinopathy of prematurity. You can also have a hemangioma that will cause also strabismus and amblyopia, and then you have other causes. Why do I worry about strabismus? Why am I worried about strabismus? Simply because if these patients do not get treated, they will have what we call amblyopia, lazy eye, which can never be treated if they're above 6. So get these patients when they're 2 years old, really, really important. Now, leukochoria. Remember, I told you every single patient, when a newborn is born to you or your family or to your friends or relatives, you have your ophthalmoscope, you should see a red reflex. The mother brought this baby in thinking he was bleeding, and this was the normal. This is the abnormal. It's this one. There is no red reflex. Unfortunately, we call it leukochoria, white papillary reflex. It's an abnormal white reflection, and it's a primary sign of retinoblastoma. Look at this. The retinoblastoma has come from the back and caused this, what we refer to as hypopian. Hypopian. You have here inflammatory cells. And if you would look in the back, remember, this is the optic disc, this is the macula. You have calcification. Very common multiple choice question. If you see calcification in a newborn, what is your first diagnosis? Your first diagnosis is retinoblastoma. So let's now talk a little about the lids. We talk about entropion, which means your lashes are directed inside. So your lid is going in, entropion. You see it nicely here, and you see it nicely here. And with time, if this is not treated by surgery and brought back out, it will cause corneal opacity. Your other one, so the same way your lid goes in, we call it entropion, your lid can also go out. And this is called ectropion. Very common multiple choice questions, okay? Here's your ectropion again. So what happens is this patient will always have allergy because the tears will always come down. Again, both of these are treated by surgery. Nasolacrimal duct obstruction, very common. Your siblings that are newly born, your relatives, children, your friends, your colleagues, you will be asked this. So I tried to put the questions that will serve you as a medical student with your family. So your nasolacrimal duct obstruction, your nasolacrimal duct is here. I thought I had an anatomy of it, but I didn't. Okay. I don't know why. Look into the nasolacrimal duct pathway. So here is your upper puncta, lower puncta, then you have your canthon, then you have your lacrimal sac, then you have your nasolacrimal duct, simply because when you're crying, what happens when you cry? Lots of tears come in and it goes into your nose and you sniff. Here, it's blocked. So instead of the tears going down, the tears stagnate, and then you get, as you see here, discharge. It's like having a drain. If the drain has to be opened for the water to go, if you block that drain, same way in these children, when they have the nasolacrimal duct obstruction, everything in your drain or your sink goes back, and with time, it becomes spoiled. This is why you get this infection. It's usually present at birth. And the best thing, all you need to tell your siblings, your mother, your that, is just to continuously do what we call a massage. You do a massage, you do a massage, and you do it for 9 months. And if this massage does not work, then we have to go in and do surgery for these patients. Ptosis, I think all of us have heard about the word ptosis. This is when you have the drooping of the upper eyelid, unfortunately. It's really very important in children to make sure, remember we talked about the visual axis, your cornea, your pupil, your lens, your vitreous, and your macula. You have to make sure that his pupil is actually seen, that the light can go through, because if this goes any further, then we have to do surgery. We talked about hypopian, which is the white fluid level in the anterior chamber, and retinoblastoma, or it could be due to pus. We also have something called hyphema. Again, this is different from subconjunctival hemorrhage. This is when you have a fluid level. And remember, we talked about the anterior chamber. It's a space. This is when you have blood in the anterior chamber. It's really devastating, and it can be caused due to blood trauma, diabetes, and blood dyscrasia or any blood disorders. Acute visual loss. We showed you the nice, beautiful retina. We have something called central retinal vein occlusion. We have something called central retinal artery occlusion. These are very common multiple choice questions. You can see this hemorrhagic diffuse retinal hemorrhages and dilated tortuous retinal vessels. This is your central retinal vein occlusion. Here, this is a very common question that people love to ask, cherry red spot. You can see it nicely here. So this is your central retinal artery occlusion. It's very ischemic. It's retinal edema. You have whitening, and unfortunately, you can have the cherry red spot. And both these cause acute visual loss. They're painless, but you can lose your vision. This again, please, your visual pathway disorders, you have to know them. This is, remember we talked about, this is your eye, this is your cornea, this is your retina, this is your optic disc, and then your optic nerve, and then your chiasm, optic tract, and then it goes into your optic radiation. You have to read on these, okay? Really important. Lesions of the optic nerve, lesions of the optic chiasm, lesions of the optic tract, lesions of the optic radiation, and then lesions of the lower optic radiation. So you have your temporal and parietal lobes, really important. And then, of course, lesion of your occipital cortex where you get macular sparing. So please, 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 you have to know these, okay? Thyroid eye disease, there will not be an exam that will not talk about thyroid eye disease, really, really important. You get what we call proptosis, or you get what we call exophthalmos, your eye is protruded. You can see that, unfortunately, this patient, he looks like he's staring. Your normal eye should cover your limbus. Remember we talked about the limbus, the conjunction between your cornea and between your sclera, which is right there. That's your sclera, that's your cornea. In the normal, your lid should cover your limbus. You should not see your limbus. Unfortunately, you have lid retraction here. I think you can see that. You also have a lid lag when you tell the patient to look down. What causes this thyroid eye disease? I like to call it thyroid orbitopathy because it affects the orbit. Your muscles, your four muscles, medial, lateral, superior, inferior, your four muscles get enlarged. When your four muscles get enlarged, what sits in between? Look at here. Look at your muscle. What sits here in between is technically your nerve. You can see it here. This is your optic disc. Remember we talked about it, right? So when these muscles enlarge and enlarge and enlarge, what sits in the middle? Your optic nerve. So what do they do to your optic nerve? They compress, they compress, they compress. And then they cause optic atrophy, which is irreversible. Diabetes is also another important chronic disease. It affects all your organs, your eyes, your kidneys, your heart, your brain, and of course your nerves, causing gangrene because of neuropathy. I only want to concentrate on the eye. It can cause a cataract. Remember I showed you the nice red reflex? This is not a red reflex, unfortunately. This is a white reflex, mature cataract, but it can cause diabetic retinopathy. Why do we call it retinopathy? Because it affects the retina. Okay, so this is your diabetic retinopathy that you can see here. This is all your exudates. This is just diabetic retinopathy, You have two types, the early and the late. And then you have something also called proliferative diabetic retinopathy. All you need to know is diabetic retinopathy, and it can cause, unfortunately, vitreous hemorrhage, which can make you lose your sight. So it's really very important for these diabetic patients to have good control before they come to the ophthalmologist. I have to treat them by laser, or I have to treat them by injection in the eye, anti-VEGF, or I have to treat them by surgery. Now, another important disease is what we refer to as Marfan Syndrome. Remember, we told you nicely, there is something here called the red reflex. It's really very, very important that you use your ophthalmoscope. You cannot leave your ophthalmology rotation without knowing how to master the ophthalmoscope. The direct, we call it the direct ophthalmoscope. You need to master the direct ophthalmoscope because you need to see this red reflex. Why do we get this red reflex? We are getting this red reflex simply because we are getting the hue of the choroid and of the retina and of the blood vessels. So when the lens is clear, when you do not have cataract, this is, see here, the lens is opacified. Because the lens is opacified, you cannot see the back or the reflex of the back of the eye, which is the red reflex. So here, it's really very important to take your, always, anytime you get an ophthalmoscope, tell your friend, just stand in front of me and look for the red reflex. This is your red reflex. If you see it like this, I don't know why they call it red, it's really orange, but we call it red. It simply says that the retina is normal. Remember what we said, your 5 layers. Your 5 layers are 1, what is it? The first layer is your conjunctiva that has vessels. Your second layer is your sclera, which is this white part here. Your third layer is your choroid. We're going to be talking a lot about it in the 5th year. The choroid. Your 4th layer is your retina. This is what you're seeing. I showed you very nice fundus photos. And your 5th layer is what? Your 5th layer is your vitreous, your gel part. So when you use your ophthalmoscope, you are looking nicely, and this is normal. What happens in Marfan syndrome? Remember what's wrong with Marfans? They have long extremities, they have long arms, they have long legs. One of the presidents of the United States, Abraham Lincoln, had Marfan syndrome. If he was not shot, he would have died of aortic dissection. The reason is, with these Marfan syndrome, this is your lens. Your lens has been dislocated. It is out of its place. It is not in the normal place behind. Remember, your lens is also transparent, but you can see the edge of it here. So instead of your lens being back here, remember what holds the lens. If we had a microscope, we would see the zonules here. You would actually see the zonules. So the zonules attached to back here, attached to your ciliary body. So what happened with this particular patient? Unfortunately, because he has Marfan syndrome, his lens has been dislocated. Remember, we talked about the visual axis. If we would take the visual axis, remember we said the visual axis is your cornea. His cornea is normal. And then the anterior chamber, his anterior chamber is normal. Iris, and then the pupil. But what's abnormal here for him, the lens has been moved. So now he needs very thick glasses to be able to see. Marfan syndrome, you have a dislocated lens. Another disease that also causes a dislocated lens is homocystinuria. I once took my children to the Intercontinental Hotel. This was about 3 years ago, before the corona. for a festival, a mahrajan. And then I was standing with my daughter, and these men started running towards me. And my daughter says, "Mom, why are these men running towards you?" I said, "No, no, no. These are my Al Faisal students. They all came. Doctora, thank you. We sat for our UCMLE exam. We sat for our Saudi medical licensing exam. We sat for our Canadian exam. And Doctora, a lot of your lectures, questions were in it. Thank you," they said. Technically, they like to ask about the dislocated lens. They like to ask about the cherry red spot. And when you come to me in the fifth year, inshallah, I'm going to be teaching you more how to sit for exams, how to sit for interviews, and how to be able to do mnemonics. When you are studying, put yourself mnemonics. You will never, never forget. When I had to go and sit for my FRCS, I had to sit for it not for to get an education, but because I was doing a paper and I had to go to London. They would not allow me to go to London without my FRCS to examine patients for our publication. When I sat for the FRCS, there was 150 candidates, and I will tell you, I was very fortunate that I was from the remaining 15 candidates that actually succeeded in the exam. And it's simply because I read a lot. I told you about the pathology. I did my pathology. Please read a lot. This is why I always say to my students, you have 3 accounts. Everyone knows the bank account. All of you have bank accounts. How do you get your salaries or whatever? So you have your bank account. This is where you put your money. You have something else called your deed account. That's between you and God. بينك وبين رب العالمين. You have your deed account. This is where you put all your good deeds. تعمل خير, it goes in there. The last thing, this is very important for you as medical students, is what? So we have 1, 2, and 3. What is the last thing? Shouldn't be the last. Is your knowledge account. Whatever you put into that account will always come back and help you. So please read. No shortcuts to medicine. Someone once told me, Doctora, what is your secret? You became the private physician to the late King Fahd in 1997. And when he died, until he died, Allah yarhamu, may God bless his soul. What is your secret? I said, there is no secret. I use my brain and I use my heart. So you have to be passionate about medicine if you want to succeed. My other secret for being, for not being fired from him as his physician, I was his attending physician to the late King Fahd, is another thing. So I told you about the first. I used my brain and my heart, never my pocket. Another thing is I always got a second opinion. We tend, unfortunately, as Arabs, as third world countries, we don't get second opinions. We think we know it all. No, always get a second opinion. I always did that with my patients. It never demeaned me, and it really, really made a difference with me staying as the attending physician, because I always got. My last sentence or so that I would like to tell you, no matter how good you are, no matter how much you go up the ladder, whether you're in the Majlis Shura, which I was very fortunate to be part of, and I want to congratulate all the females. You can now drive. We fought and fought for you in Majlis Shura until we got it. We also the card and everything else. But let's go back. So technically, no matter how high you go, whether you're in the Majlis Shura, whether you're the attending physician to the #1 man in the country, whether you take all these wonderful honors from different, never, never forget your underprivileged patients. Your underprivileged patients always need you. And I always say, da'wa minhum, one prayer from these patients will open the doors of heaven, especially in this holy month of Ramadan. I would like now to thank all of you. I will stop the sharing. And I think I've covered most important things. I cannot cover everything. My 5 lectures will have covered everything that I've given you as multiple choice questions that I have submitted for you for your exam. Again, read, read, read. Thank you all very much.
Thank you so much, doctor. Thank you. Doctor, there's a question on the
Please
chat.
go ahead.
Yes, in the chat there is a question. Okay. So what is the difference between the presentation of herpes simplex virus dendrites and herpes zoster ophthalmicus?
Okay, there's both. In herpes simplex virus and in herpes simplex zoster, you get the dendritic keratitis. At your level, you do not have to differentiate between the two. This is for us. This is when you become an ophthalmic resident. The most important thing is you treat them with the antiviral. You'll never be asked that in the second year. So I don't want to go, I only want to concentrate on the things that you should know at your level. And they are both treated by antiviral.
Okay, thank you, doctor. There's another question. Does accommodation trigger strabismus in hyperopia patients?
Okay, very important. In strabismus, we said we have 3 things. One, 3 types of strabismus: hyperopia, 3 types of strabismus: esotropia, exotropia, the eye is out, and hyperdeviation. We took esotropia. All esotropic patients will have a refractive error. There are also 3 refractive error. There is hyperopia, there is myopia, and there is astigmatism. With esotropia, you always have to have, if you go back to my lecture, it's there. You always have to have hyperopia. Technically speaking, these small children, their life is all here. It's right there. So technically in hyperopia, you can see at the distance, right? But you cannot see near. And these children who are who have hyperopia, always their life is right under them. So therefore, when they look to the close objects, they will develop accommodative esotropia. That's why we have to put on the glasses, we have to patch them, or we have to do surgery.
Okay, thank you, doctor. Doctor, there's another question. In the slide in seventh nerve palsy, the site of the lesion was written as supranuclear. Is that wrong?
Which slide was that? No, it's right. It should be right. I'll have to go back, but the slides are correct.
Okay, thank you, doctor. There's another question, last question. Do we use fluorescein stain for corneal aberration and herpes zoster and herpes simplex dendritis?
Okay, what we do is anytime you have a lesion in your cornea, anytime there is a lesion or you're suspecting any lesion in the cornea, you have to put this fluorescein stain. This fluorescein stain helps me, it guides me as a surgeon. So when I put the fluorescein stain, if your epithelium, I told you your epithelium is nice and smooth, if there is any disruption from your epithelium, whether it's due to an epithelial defect, herpes zoster, herpes simplex, whether it's due to dry eyes, whether it's due to any corneal ulcer, whether any foreign body, it will pool because it is no longer a smooth surface. So we use the fluorescein stain simply for one thing. We use the fluorescein stain to be able to diagnose more or less, if you will, the abnormality, or what we refer to as the epithelial defect, or the abnormality or the non-smoothness of your corneal surface. I hope I have made that clear.
Thank you, doctor. Doctor, another question. Do they have to know every abnormal picture? Do they have to memorize them?
I'm not sure what, I don't want anyone to memorize
Abnormal.
anything. Please never memorize. You have to understand. This is why I said put yourself mnemonics. If you memorize something, when the exam is done, it's gone. Just understand it. And if you don't understand it, you're lucky now. You've got the Google. My God, I wish I had the Google. I remember when I wanted to, I never even got the slides of our doctors. You have the slides. You have, I mean, I'm telling you, I envy each and every one of you because you have everything at your fingertips. Never memorize, always understand things. The more you understand, the better it will be. I think it's 4 o'clock now.
Yes. Yes,
I
doctor.
don't want to take up their time. Are there any more questions?
Doctor, let me check. Doctor, there was a picture in the lid lecture which wasn't labeled. Can you please tell us what the labeling was?
If it wasn't labeled, it means you're not going to be asked.
Okay. Yeah. That was the
Like,
last question, doctor.
I don't want to go into too much. I only want to show you the things that are, by the way, today, what the things I showed you were not so much for the exam as so much it was for your normal life. When your parents, when your siblings, when your colleagues ask you, your exam is going to be those 5 lectures I gave you. So today I just wanted to make it a review and for you to understand this was not really so much a review for your exam as much as it was a review for ophthalmology as a whole so that you can be good physicians later and know the importance of ophthalmology because the eye does not sit alone. The eye is part of your body. So it's the window to your body. Remember what I said, the emergency preservation of life, of the limb, and of your sight. Hopefully, I'm going to see you all in the 5th year, and I am going to grind you, and I am going to teach you everything you need to know, inshallah, about ophthalmology as physicians. I'm going to teach you about body language. I'm going to teach you about leadership and how you can become a leader wherever you're at. And this is so important, but always remember, have your head always straight, always talk straight ahead. And if any of you want to know more about Salwa Alhazza, there was a program a couple of days ago. It was called Al Masar. It was the 5th episode. Please open it. I talk a lot about my hardships in in medicine, and I also have a lecture called My 40 Years Journey in Medicine. If you can find that, that would also be good because it really teaches you a lot about leadership. But open this program. It's called Al Masar, and it was on the Saudi channel, and it was the 5th episode. Thank you all very much.
Thank you so much, doctor. The students really enjoyed the lecture. Thank you.
Thank you very much. Bless you all.